Hello, thank you for joining us. I'm John Ryan. Today we're going to talk about pathways to improved care in pulmonary arterial hypertension. So I'm a cardiologist and I work at University of Utah here in Salt Lake City. I'm trained in heart failure, transplant, and pulmonary hypertension. We have a combined program here comprised of cardiologists, pulmonologists, advanced practice clinicians, nurse practitioners, physician assistants, nurses, medical assistants, pharmacists, and care coordinators. We think it's important to take care of all the forms of pulmonary hypertension because first of all, they all have an effect on mortality, but secondly, they also makes you more aware of the number of people who have pulmonary arterial hypertension. When I was growing up, when I was in medical school, I went back and looked at what I learned about pulmonary hypertension in medical school. And it basically, the text read, there was one paragraph, and the text read, pulmonary hypertension is so rare, you're never going to see it. So don't worry about it. And then it went on to say that there's also no treatment available. So really, if you do see it, don't worry about it. Obviously, that has changed considerably over the last several years. When we diagnose pulmonary arterial hypertension, we have tools that we use. As I said, the first issue is that you notice that someone has pulmonary hypertension. And in that setting, it's important to start doing a workup for the underlying etiology, the underlying cause. So we have tools that we can use, and we have algorithms in place to make the diagnosis. However, there is still a delay in the time to diagnosis. Unfortunately, there is still a delay of up to 3 years in terms of people being diagnosed with pulmonary arterial hypertension. The other aspect of treatment that's becoming increasingly important and increasingly commonly used is the concept of risk assessment. You can diagnose a pulmonary arterial hypertension now, or you have diagnosed somebody with pulmonary arterial hypertension. So what is their risk? What is their risk of dying over the next year? What is their risk of being hospitalized over the next year? And these tools are then useful to determine the treatment of pulmonary arterial hypertension. Now, I will say that this is going to be the backbone of our talk today, diagnosis, screening, and risk assessment. We will not be touching on treatment today. Now, there is the normal PA pressure. What if you are normal and healthy? The average PA pressure is 15 millimeters of mercury. And interestingly enough, this is actually uniform across the entire animal kingdom, the entire land-living animal kingdom. Giraffes, their average PA pressure is 15 millimeters of mercury. Rats, 15 millimeters of mercury. Rabbits, etc. All animals in the animal kingdom have an average PA pressure of 15 millimeters of mercury. When pulmonary hypertension was initially being classified and identified, Paul Wood was involved, later Stuart Rich was involved, it was determined that they really wanted to make sure that the patient truly had pulmonary hypertension, truly had pulmonary vascular disease. So therefore, the cutoff, as I said, normal is 15, the cutoff was 25 millimeters of mercury. If your pulmonary artery pressure was greater than 25 millimeters of mercury, then you had pulmonary hypertension. Now this is also in a time and an era around the early 1970s when there was the hemodynamics were not computerized, say. The echoes were not as common or as well done as they are now. So you really needed to make sure that someone had pulmonary hypertension before, for example, you gave them that diagnosis or started them on some form of therapy. However, now it's been identified through the work of Brad Marin and others that actually your prognosis starts to go down once your pulmonary artery pressure, the average pulmonary artery pressure goes over 18. So now the cutoff is changed to 20 millimeters of mercury. So now the cutoff for pulmonary hypertension is 20 millimeters of mercury, greater than 20 millimeters of mercury. And that was put forward through the 6th World Symposium. This is interesting because it's obviously changed our practice, and now, by definition, we had more patients who were diagnosed with pulmonary hypertension. There is still an issue of pulmonary vascular resistance, Normal pulmonary vascular resistance, often abbreviated to PVR, is 1 Wood units, named after Paul Wood, who I mentioned earlier. The cutoff for pulmonary arterial hypertension is greater than 3 Wood units. Now that may change over time as well. It might, or at least it's been brought up that this might result in an earlier diagnosis. I'm actually not sure about that. And also I'm not actually sure if earlier diagnosis results in a better prognosis. It certainly leads to what's referred to as a lead time bias, which is that if you were diagnosed with previously, if you're diagnosed with pulmonary hypertension when your mean peak pressure was 27, and now you're getting diagnosed at 22, you certainly are going to live longer with your disease. That's because your disease was diagnosed at an earlier stage, not necessarily because the treatments were introduced earlier and have been beneficial. So it gets hard to iron out. It's important when you have a diagnosis to have developed within your program or within your clinics a personal diagnostic approach in patients with pulmonary arterial hypertension. It's important to determine which tools to use for which patients. And to look at the diagnostic algorithms and see what can you do in your center to diagnose pulmonary arterial hypertension. One of the commonest things for us actually as a referral center, one of the commonest things for us is that in a center where there are dedicated pulmonary hypertension programs, it is much more straightforward for us to do the diagnostic work. And oftentimes people are referred to us for just that. Dr. Ryan, got an echo, looks like they have pulmonary hypertension. Can you take care of it to help get me a diagnosis? The answer to that is always absolutely. And the diagnostic approach involves several aspects. It involves blood work. It's important to get a blood count, CBC. Anemia obviously is a significant comorbidity in all forms of pulmonary hypertension. It's important to look at the kidney function. Poor kidney function is also associated with pulmonary arterial hypertension. It's important to look at liver function, liver disease. Liver disease increases the risk of what's referred to as portopulmonary hypertension. Pulmonary hypertension due to liver disease, end-stage liver disease, cirrhosis, fatty liver, etc. Then it's, again, continuing the lab tests and check the glucose, see if they have diabetes. Diabetes would obviously be an indicator of pulmonary hypertension due to left-sided heart disease. Or if they are obese, could be a form of obstructive sleep apnea causing pulmonary hypertension. Those are the bulk of the lab works. HIV, however, is another important test. It's uncommon for someone these days to not know they have HIV, but again, it's another important test if you pick up someone with pulmonary hypertension. Then after the lab work, there's one more, BNP. Forgive me, I left one out. BNP, brain natriuretic peptide. Terrible name, because it actually originates from the heart. And it gives you an idea as to the prognosis of the pulmonary hypertension. BNP is very high, then it is associated with poorer prognosis. Now, after the labs, that's truly it. After the labs, then, you're into your next set of, I think your imaging tests is what we do next. Do a chest x-ray. Make sure they don't have wicked bad emphysema. You can also do a CTPA, CT scan of the chest, looking at the pulmonary arteries. Helps give you an idea about the size of the pulmonary arteries, the size of the heart, but also if there are blood clots present. And blood clots are important because, as I mentioned earlier, chronic thromboembolic pulmonary hypertension is another etiology, chronic PEs. The best way to definitively rule that out is a VQ scan. So that's another image that you do, a VQ scan, ventilation perfusion scan. Over the last year with COVID, with concerns about ventilation, that has been adapted a little bit, but it seems that we're getting a little bit more back to normal. Now, in addition to all of those, you're also assuming that you have an echo at this point in time. And most patients referred to me have an echo done prior to being referred. It is very rare that someone will come into our clinic saying, oh, I feel short of breath, I think I have pulmonary hypertension. Typically they'll say, I felt short of breath, my provider got an echo, it showed pulmonary hypertension. But there are some subtleties that may not be done in previous echoes. We think it's important to do a bubble study. Bubble study involves injecting some agitated saline into the arm. It's very safe. But what it does is it shows you if there is a hole in the heart, atrial septal defect, ventricular septal defect, all of which are associated with pulmonary arterial hypertension. Increasingly then, in centers such as ours, people are doing cardiac MRIs. Cardiac MRIs again help for the ASDs, VSDs, congenital heart disease, but also help in terms of prognosis. Big right ventricle, poorly functioning right ventricle seen on MRI, again is associated with poor prognosis. So, as I said, these diagnostic workups are very common in centers of excellence, which is why referrals are important. We do labs, we do imaging. What do we do next? We do pulmonary function tests, other forms of testing. Pulmonary function tests. Obviously, if you have, for example, emphysema, restrictive lung disease, obstructive lung disease, this will turn up on pulmonary function tests. There is also another test there called the DLCO, diffusion capacity, and that can give you an idea as to the presence of pulmonary vascular disease, as well as giving you an indication again of prognosis. After the PFTs, we do a 6-minute walk test, get the patient to walk for 6 minutes, see how far they can go. One of the other tests we do is an overnight pulse oximetry, screen them for sleep apnea, which is very common in this country and is very common in settings of obesity, and in and of itself is a cause of pulmonary hypertension. And then after all these tests, we do a right heart catheterization, measure the pressures in the heart if we feel that we're not sure what the diagnosis is, or if we feel we're going to start pulmonary arterial hypertension specific therapies. The diagnostic workup is pretty similar between those outside of pulmonary arterial hypertension centers versus those inside. History is always the same. History is history. We look for the symptoms, we look for the signs. The symptoms overwhelmingly are almost always shortness of breath. And actually the workup, although it's arduous and we just went through it, it should actually still be the workup that you do for people who come in short of breath. You should still do PFTs. You should still do chest x-ray. You should still look for anemia. Still do a BNP. So there's actually, we don't see a difference between the workup for shortness of breath versus the workup for pulmonary hypertension. But as I said, you've got a history, you've got symptoms, you've got signs, you've got lab tests suggestive of pulmonary hypertension. One more set of lab tests that I forgot to mention were the autoimmune diseases, things like lupus, scleroderma, less commonly rheumatoid arthritis as a cause. So you check ANA, ANCA, CRP, ESR, SCL70, other autoimmune diseases. And again, these might give you a potential etiology of pulmonary hypertension. And then you get the echo, and that shows the probability of pulmonary hypertension. If the probability is low, then you consider other causes for shortness of breath. The PA pressures are low on the echo, if the right ventricle looks just fine, then you think about other causes. If the probability is high, intermediate or high, you can refer them to an expert center. We're delighted to have them. It is important to do a VQ scan. CTEPH will talk about time and time again when we talk about the work of pulmonary hypertension. The reason being is because it is a curable form of pulmonary hypertension. You do surgery. Do surgery, you can cure the pulmonary hypertension. You then consider the risk of left-sided heart disease, the pre-test probability. These are things I already mentioned: diabetes, I mentioned obesity. Other things, coronary artery disease. Other things such as atrial fibrillation, left ventricular hypertrophy on echo, left atrial enlargement on echo, diastolic dysfunction on echo. The echo can really be a key tool here to determine if you think the patient has left-sided causes of their pulmonary hypertension. Then, as we mentioned, lung disease as well: obstructive sleep apnea, obstructive lung disease, restrictive lung disease. And then once you make that diagnosis, you refer, at least you have the option, and it's recommended to refer on to a pulmonary hypertension expert center. Within the expert centers then, the diagnosis isn't much different. We still do a VQ scan if it hasn't already been done. We still do the diagnostic imaging that we went through. And then we refer for a right heart catheterization. If pulmonary hypertension is not actually present, then, as I said, you look for other causes of the shortness of breath. If the pulmonary hypertension is confirmed, then in most centres such as ours, we have a multidisciplinary team review. Cardiologists, pulmonologists, nurses, pharmacists, everyone looks at these cases and determines what's the next step. If they have CTEPH, you've classified their pulmonary hypertension, then you're planning to refer for surgery. If they do not have CTEPH, then you form an alternative classification. Group 1, pulmonary arterial hypertension. Group 2, left-sided heart disease. Group 3, chronic hypoxic lung disease. And then you initiate the appropriate treatment. If it's hard to make a classification, I've had one patient with all 5 groups of pulmonary hypertension as a risk factor. And so if it's hard to make that classification, then you consider trials of treatment and you monitor and reassess and determine if it's been impactful on their symptomatology. So what are the considerations for screening of pulmonary arterial hypertension? Well, first of all, you need to have a high index of suspicion. That's changed over the years. As I said, when I was a younger man, we were told that you're just not going to see pulmonary arterial hypertension, so you don't need to worry about looking for it. That's changed, as I said, over a couple of years. There are then also high-risk diseases. Scleroderma, we mentioned already. Liver disease, we touched on. HIV. So if you have someone with these underlying conditions and they come in with shortness of breath or other symptoms, lower leg swelling, you need to think about pulmonary hypertension as an etiology. As you've probably gathered and as you're probably aware, echocardiogram is the screening test of choice to pick up pulmonary hypertension. Now that being said, it's very easy when you do the echo and the estimated pulmonary arterial pressures are quite high. If they're not high, then you can still look for other signs. The right ventricle is big, the right atrium is big. And if you have a really high index of suspicion, you can say, listen, the echo didn't show a high pulmonary artery pressure, but I'm really concerned that they have pulmonary hypertension, so I'd like to refer them on or do a right heart catheterization. The diagnostic evaluation, as I said, is thorough and in particular requires ruling out chronic thromboembolic disease. The other reason why we do right heart catheterizations is to determine and to initiate pulmonary arterial hypertension therapies. You cannot start PAH therapies in this country without a right heart catheterization. And then, as I said, we do a 6-minute walk test to determine their functional class. Now, risk assessment has become increasingly common and important in the management of pulmonary arterial hypertension. There's lots of risk assessments out there right now, so it's important to choose the one that's right for you. There's the European Respiratory Society, which I'll show in a second. There's registry data, French registry, Compara registry. These give you an indication of risk. And then there's the Reveal 2.0 risk calculator, which I actually find the easiest. Gives you a number of what their score is, gives you a percentage as to what their risk of mortality is over the next year, and then helps guide, at least as you interpret that, then that helps you guide therapy. There are 3 broad classes of risk: low risk, intermediate risk, or high risk. High risk has the highest mortality, oftentimes 20 to 30% over the next year. Intermediate risk has the second highest mortality, oftentimes 5 to maybe 15% over the next year, maybe 10%. Low risk, it's important to know, is not no risk. And the risk of mortality with low risk is somewhere between 1 and 5% a year. Still quite significant. As I said, then the risk assessment guides you as to your therapy. If you're high risk, you use parenteral prostacyclins, very aggressive, typically use very aggressive therapies. If you're low risk, maybe you can just treat with dual oral combination therapy, at least for a period of time, and keep people out of trouble. And again, this is the experience that comes with multidisciplinary care for pulmonary arterial hypertension. So here are the 2 main risk tools that are used. The European Respiratory Society. As I said, this divides people into low risk, intermediate risk, or high risk. A lot of these tools more or less do the same thing. They look to see, do they have signs of right heart failure, yes or no? How fast are the symptoms progressing? Are they having syncope? Very bad prognosis. Automatically, if it's repeated, puts you in high risk group. What is their functional class? Do they get short of breath inside the house? Do they get short of breath outside the house? Do they get short of breath at rest? If they're short of breath at rest, that's functional class 4. Automatically puts you in high risk. If they're able to do a lot of things, able to go to the store, probably puts them in functional class 2. Probably keeps them low risk. And then if they're getting short of breath, dressing, washing the dishes, walking around the house, that's probably puts them in intermediate risk. The 6-minute walk distance, which we mentioned, is useful for prognosticating. A normal 6-minute walk is about 600 meters. If it's over than 440, again, fall into a low risk. If it's somewhere between 165 and 440, intermediate, forgive me, over 440, it's low risk. 165 to 440, it's intermediate, and then less than 165, it's high risk. Some people use CPET, cardiopulmonary exercise tolerance testing, to prognosticate. We use BNPs, and then the imaging, I already mentioned. Big right atrium, bad prognosis. If they have a pericardial effusion, fluid around the heart, bad prognosis. And then hemodynamics. I've often said that in pulmonary hypertension, in risk, if you play the game risk, Australia is the key to the whole game. In pulmonary hypertension, the right atrium is the key to the whole game. If you have a high right atrial pressure, greater than 14 millimeters of mercury, you are at high risk of development of mortality from pulmonary hypertension. Low cardiac index, low oxygen saturation in the venous side, high risk patient with pulmonary hypertension. The REVEAL registry then, in contrast to the European registry where you end up circling these things, the REVEAL 2.0 registry then actually gives you a score. Many of the features are the same. Function class, 6-minute walk distance, BNP, right heart catheterization. There are some other things in there, comorbidities, vital signs, heart rate and blood pressure, they're in there as well. The advantage that I find with the REVEAL registry is that, as I said, it helps you, gives you a score, and then you can bring that score to your patient. And patients will ultimately even ask you, what's my score this month or this visit? And then you can determine treatment from there. So there you have it. That's the approach to the diagnosis of pulmonary arterial hypertension, an algorithm that you can use, screening tests for people in particular at high risk or coming in with shortness of breath, and then a risk assessment when people have been diagnosed with pulmonary arterial hypertension to help you guide your treatment. And the key, no matter where you're providing this care, is to make sure you have a multidisciplinary team involved. This is not an individual sport. This is a team sport. So we would ask you now to complete your post-test and evaluation. This has been a positive experience for me. Hopefully it's been a positive experience for you too. And this is also the way in which you get CV credits. Thank you for your time. This has been an absolute pleasure and hopefully beneficial. Good luck.